Hello, I'm Gregg Simonson, Director of Strategy, Innovation, and Partnerships at International Diabetes Center, HealthPartners Institute in Minneapolis, Minnesota. Welcome back to Ketone Connect, Innovative Solutions to Prevent Diabetic Ketoacidosis, a new educational series on important topics and advances in the care of people at risk for diabetic ketoacidosis. This is episode 4, pairing continuous glucose monitoring and continuous ketone monitoring to prevent diabetic ketoacidosis. Joining me for this discussion today is Dr. Jennifer Sherr, Professor of Pediatrics at Yale University in New Haven, Connecticut, and Dr. Richard Bergenstal, Executive Director of International Diabetes Center, HealthPartners Institute in Minneapolis, Minnesota. Well, thank you both for joining me. Jen, let me start with you. What methods are currently available to measure ketones in people with diabetes? And are there any challenges to using the current technology?
Absolutely. So we currently have two methods that are used to assess for ketones. One is to measure acetoacetate by checking urine. The other is to do a point of care capillary test, which will measure beta hydroxybutyrate. Now, in terms of problems with these current measurement strategies, they absolutely exist. The biggest one being that people with diabetes need to initiate the test. They need to be thinking about ketone monitoring, remembering to go ahead and do it. Now, if we go into the specifics of the individual testing modalities, for urinary measures, the important thing here is that we're measuring acetoacetate. We're not measuring beta hydroxybutyrate, which is the predominant ketone body in DKA. So what's the problem with that? There can be a delay in detecting a rise in ketone levels. And then as we're clearing ketones out, there's a delay in seeing resolution of ketosis. Other problems that exist with this modality, you have to find a bathroom. You have to make sure to carry the strip. And there's definitely short half-lives in terms of the strips being effective and providing good results. Now, in terms of the capillary measures, years ago, people had their glucose monitors on them. With the advent of CGM, I don't see as many people carrying meters around. So a lot of times people don't have access to do a finger stick. And it's relatively expensive. And you need to understand that a numerical value doesn't always mean something's wrong. It can just indicate a level. And that's going to be really important to be considering in how we interpret these results.
So excellent. So given these challenges, Jen, that you just mentioned, is it accurate to say people with diabetes are not frequently measuring ketones?
I think we can take frequently out of there and just say people are not measuring ketones.
That's correct. Okay.
It's not happening.
Okay. So that's good to know. Okay, Rich, I'm turning over to you. So Jen just stated that ketones are not consistently measured for people with diabetes. But kind of clearly, why is this important? And why should ketones and glucose be monitored to prevent and manage DKA?
Yeah, no, I completely agree with Dr. Sherr. The ketones, just the devices aren't there. They're not ready. Well, when you need them. So here's one slide that really summarizes and makes a point. And I really feel privileged to present it because this is much of Dr. Sherr's work, weeks or months of work where she did insulin infusion set interruption studies where you have people with diabetes on insulin and having it infused with an automated insulin delivery system, and you stop the infusion and you watch very carefully in her laboratory, monitoring the glucose and the ketone rise. So look at the glucose in the lighter blue and the ketones in the darker, and you see just a picture unfold to say, is it okay just to measure my glucose and only measure ketones later? And let's look at the panels here. On the left, sometimes the glucose goes up a lot faster than the ketones. Those are two examples there on the left. And then you'd say, well, then I'm set. I'll just follow the glucose and see what happens. In the middle, they go up together. And again, you might feel comfortable. Well, as soon as I get high, then maybe I'll check my ketones because they're kind of going in parallel. But over on the right-hand side is really an important learning that Dr. Sherr taught us all, that the ketones can sometimes go up faster than the glucose. And they cross these levels. You can't read the exact numbers here so clearly, but they go to important warning levels of ketones before the glucose is even elevated in many cases. So I like to just summarize this, and it's all her months and months and years of honing this technique to say, if you want to know what your ketones are, you really need to measure them. You can't just go by your glucose. Continuous glucose monitoring has been terrific. It has reduced some of the hyperglycemia burden, and it's reduced the amount of risk for DKA, but it has not eliminated it. And this slide shows it so well. So I thank Dr. Sherr for all the hard work to teach us that.
Yeah, I think that is a nice point in the end. You just can't rely on the glucose. You need to have both. Well, Rich, it's a perfect segue now. So there's a sensor that's being developed that'll give us continuous measurement of both glucose and ketones. And so that's in current clinical development. So what would be the benefit of having a unified monitoring system for both glucose and ketones?
Yeah, well, again, Jen set the stage nicely. I mean, if you need to measure them both, wouldn't it be amazing if we actually had a system that just measured them both with the same sensor? And that's what's in development now. So we're all rooting for it, but we know there's high hurdles of accuracy and safety and efficiency that they have to go through to get it approved as a device. But here's the system that's being tested currently, where you take a current, very small, accurate, continuous glucose monitor, and on that same filament on the sensor, you layer in the beta hydroxybutyrate sensors, and on one device, you insert it and it measures both. So it's a dual glucose ketone monitor. And actually, we have to get used to sort of saying that, the dual glucose ketone sensor. And the reason it would be important to me is, if you need to measure ketones, you don't want two devices, you don't want two apps, you don't want to be going back and forth. You want the data to come in coordinated, and you want to get the alerts on the same app. You want to be alerted when your glucoses are high or low. You want to be alerted when your ketones are high. And you really don't want to know about the ketones when they're normal. Just be silent and just let me know when they go up. So I think this dual system, if approved, has a tremendous potential to give us a chance to reduce that risk and nipping the ketones in the bud when they're just starting to go up.
Well, especially since you don't need more real estate. One sensor, that's
one
nice.
sensor, one site.
Okay, so Jen, can you give me a scenario then to highlight how and why a dual glucose ketone, sensor might work or be clinically valuable?
Absolutely. So, building on what Rich was talking about earlier, these insulin interruption studies that we did, this is the case of a 6-year-old who came in for this insulin interruption study. And what you can see at the top in the black is her glucose levels throughout the course of the study. The yellow represents her ketones. You could see the time we turn her pump off, and you see this little bump in her glucose, and that likely represents when we went to go place her IV, because kids get nervous. There's a bump, and then you see her settle back down. But what's really interesting here is, as we're going ahead and suspending her basal insulin delivery, you see that she crosses that 1.0 millimole per liter line for her beta hydroxybutyrate level. And that occurs before her glucose exceeds the threshold of 250. So in clinic, I'm always telling people, please measure for ketones when you're 250. Please measure for ketones when you're 250. Now what happens? Nobody measures ketones, right? And so it's great that we have these thresholds. What we've learned is exactly what Rich said. If you want to know what your ketones are, you've got to measure it. And it's happening at thresholds that are lower than we thought. So I hope this provides a sense of infusion set failures are something that people with diabetes live with every day. They're always at risk for these. And so it'll be a great method to go ahead and detect something like that occurring.
And Jen, can I just ask, is that 1.0 what you were watching carefully, or do you like a 1.5, or what gets you nervous?
Yeah, no, I mean, we actually would continue the studies well past that 1.0.
Yeah.
We would let people get up to 2.5, 3.0. So we were trying to do as much and push as much as we could.
Yeah.
1.5, I'm going to start being more concerned about. We did have people in the study reach that threshold and just continue to monitor, because we wanted to get assessment of the accuracy of the sensor and look at it at various levels. But I think clinically, just like the expert recommendations state in the Lancet, which was just published last month, that 1.5, I think, is going to be a good place for us to start thinking about, okay, I need to do something right now. And we're going to learn a lot more as we see a lot more data collected in the real world about what thresholds are going to be important, clinically important.
Gregg, can I ask her one more question?
Sure.
And were there did people to get some symptoms during this when you let them go and they're starting to rise up to?
No, people just were sitting in bed watching TV. Some kids were doing homework. Some kids were pretending not to do homework, having conversations with our staff. So people felt generally well. And again, I think that this speaks to the fact that, sometimes with ketone development, you're not feeling anything. And that's why measuring is going to be so critical. Because what we know is when you see the pump go on, we were giving a ton of insulin to bring them back down. And that insulin worked, but you had to know to give it and to be more aggressive with that insulin delivery.
Okay. Good.
Yeah. And I think on the next slide, we had some of the implications of a dual glucose ketone monitoring system here.
Yeah. And I think, sorry, I was just going to say, I think there's a ton of ways that we can be using it, identifying insulin infusion set failures, detecting ketoacidosis in peds. We have so many people who go ahead and have recurrent episodes of DKA. How do we prevent that? And then even, thinking about how do we add value to automated insulin delivery systems? How do you think about kids when they're ill? So many parents call and say, my kid has the stomach bug. And we're like, did you check for ketones? No, not yet. They may just have ketones. Ketones can cause nausea and vomiting. So I think we're going to learn so much in so many facets of care.
Yeah, great point. So, Rich, Jen's talked about potential uses of this dual glucose ketone monitoring system in the kind of pediatric population. What about in adults? Anything different or something, things to highlight that might be different?
Yeah, I mean, I think you look around that circle and certainly all of those apply to adults. And I just highlight a couple of things that might really stick out. So adults are more likely, maybe peds will catch up soon, but more likely to be using SGLT2 inhibitors. So these amazing new drugs that I think everyone listening knows their potential value of not only lowering glucose, but cardiorenal protection, heart failure. So type 2s are likely to have our adults are more likely to be on those medications, and that raises your ketones while it's letting the glucose flow out in the urine. So this euglycemic ketosis or potential for ketoacidosis. So I think that's one key reason adults. And I'm not so sure. And Jen may know, even though she's in pediatrics, you've done the adult testing. Maybe the symptom threshold is a little different. Some elderly adults. What do you think, Jen? Any difference?
In terms of the studies we didn't see a difference in symptom development.
Yeah.
But again, I think if you are aware that, it may be important, people may be more cognizant of symptoms if they see an elevated threshold, right? You may be querying yourself more. So I think there's a lot that we're going to learn and continue to explore as we get access to real-time ketone data.
Yeah, and then just as Jen mentioned about the sharing, I think some elderly adults, and they're on this monitor, to be able to share that device data with someone else. And so I understand they're going to try to be able to share not only your glucose, but share your ketones, so others can be alerted to a frail or elderly person who might be slipping into some ketosis. So I think for adults, there's many situations where it's going to be helpful.
Great. Well, we're coming close to our end of our discussion today. Any quick last parting thoughts we'll start with you, Jen, and then on to you, Rich.
I'll just say I'm super excited about the advent of this technology and what it's going to bring, what we're going to learn, and how we're going to be able to provide better care for people living with diabetes. So I'm excited for what the future holds.
Yeah, I just think we're going to need to teach patients, what are the signs and symptoms, and how do you, and teach clinicians how to respond to it. And then we've got a real chance to bend this curve of the ketoacidosis that's really out there today that we're not dealing with very well.
Yeah, I see a need for a lot of education, both
Yep.
for individuals with diabetes and the clinicians that care for them.
Yep.
Well, thank you both very much for joining me today. So for our audience, don't forget that all of our episodes are recorded and saved to the Medscape social media platforms. Yeah, there is a dedicated Medscape playlist on YouTube as well. So please bookmark this page, like our events, and subscribe. Now, if you would like to earn CME or CE credit for this, you easily can do that. You can see this QR code here that you can use that, or the website's listed here. And please join us next month as we get into the nuts and bolts of DKA prevention and management in the pediatric population. Our guest will be Dr. Amy Kriegel, a pediatric endocrinologist and medical director here at International Diabetes Center, and she will join us for episode 5. So please join us for episode 5, claim your credit. Thank you again to our faculty. Have a great day, everybody.